Good morning. My name is Brendan Dewitt. I'm in the Chem 1005 class at the University of New England. I'll be going over two cases. In this presentation for Case Connections Unit 4, Case 3 and Case 4 will be discussed in this presentation. Here's that. I would like to preface this too. I have had a cold and stuffy nose for this past week, so the cough and stuffy nose, I greatly apologize. In case 3, the 47-year-old man was admitted to the ER due to toe pain, causing him to be unable to bear weight here. We'll switch over, sorry. In that great right toe, he's unable to bear weight, and he reports that pain started last night. Upon further investigation with the full physical exam and laboratory samples, the man received a gout diagnosis, actually. There's a chart right below. The question there is kind of the comparison between normal lab values and those collected from the patient. The patient has a high value of plasma urate at 10.5. And then the uric acid within the body is produced in the liver and is involved in purine metabolism as an end product. The patient presented with the low urinary uric acid values at 215, and that's compared to that normal range of 413 plus or minus 78. An overall lower output of urinary uric acid shows the accumulation of uric acid within the body, leading to gout. Next, we'll kind of discuss what gout is. Gout is a condition caused by hyperuricemia as uric acid builds up in the body. Uric acid crystals, monosodium urate, accumulate as purines are broken down in the body there. This affects the joints, and most commonly, like our patient is dealing with in that big toe. Some of the symptoms are redness in the skin and also pain and swelling. All right. In this patient, there are 3 options to explain his gout presentation. The first there is overproduction of purines. The second is decreased salvage of purines. And that final one is decreased urinary excretion of uric acid. We'll go over that best explanation here a second. In that best explanation, obviously, as we can see, without the one crossed out, is decreased urinary excretion of uric acid. The patient has lower urinary uric acid and higher plasma urate than normal values. This shows a buildup of monosodium urate, and this patient is presented in the formation of gout there. And those values are kind of talked about in the above slide too. This shows a buildup of that monosodium urate in this patient, and then overproduction of purines, which we'll talk about next. Is most close to the legit diagnosis, but it just made more sense that the decreased urinary excretion of uric acid was the main diagnosis over overproduction of purines, and that will be talked about here a sec. The overproduction of purines have an effect on specific enzyme abnormalities, but there is a lack of testing for specific levels in the body that would point to a disturbance in the salvage pathway and production pathway. The enzyme HPRT can be deficient in cases with overproduction of uric acid. HPRT is an enzyme that is part of the purine salvage pathway, and when deficient can cause overproduction of uric acid as the purine salvage pathway is inhibited. As we can see in this graph right here, we have the de novo synthesis, which we'll talk about pretty soon, the salvage synthesis, and then the HPRT right there. All right, the enzyme, the HPRT enzyme itself prevents hypoxanthine and guanine from collecting and converting into uric acid, which causes that gout inflammation. In this graph, as I just pointed out, the HPRT enzyme is described, and then we can kind of see what happens when it's deficient, and that kind of is depicted in the graph here. Another important enzyme of the purine metabolism is the de novo purine synthase pathway and the PRPP aminotransferase. PRPP is used as a co-substrate with the HPRT in the salvage synthesis ultimately from the purine bases hypoxanthine and guanine. We can kind of see all this stuff, how it interacts with each other there in this graph. Deficiency of HPRT leads to the accumulation of these bases as discussed, and further to accumulation of uric acid that is converted into the xanthine oxidase. This scenario results in a purine overproduction and thus uric acid accumulation for gout presentation. But in this patient, there's no values that would point to this. It is possible overproduction of uric acid is seen in the lab values, and it would explain gout more so. Decreased salvage of purines right here, kind of going off of this graph as well, would not lead to the increased uric acid accumulation in gout presentation. This value is not seen in the initial values given by the patient either. And then what is potential impact of dietary modifications on the presentation of gout? The patient shared that he switched from diet soda to regular soda due to reading that diet soda has fake sugar. The patient has a high value in fructose as he drinks more regular soda than diet soda. Increased fructose shown to correlate with increased uric acid production. A study shows that fructose supply increases in the body to lead to ATP use in fructose phosphorylation. This in turn increases levels of ADP as a substrate for uric acid formation. Okay, now on to case 4 here. We have a 58-year-old patient who is admitted to the ER due to experiencing progressive fatigue and weakness. The patient is also experiencing many other symptoms as well throughout a thorough physical and neurological examination. Some of the symptoms that this patient came in with is shortness of breath after walking several blocks. She mentions mild diarrhea as well, and then some tingling in her lower extremities and loss of balance while walking. She declined any neurological or cardiac symptoms. And then on the physical exam, we learned some more vital information that led to the diagnosis, or what we suspect as the diagnosis that we'll get into. So we were kind of looking at 3 vitamins here. We'll show them here, B6, iron, and B12, and kind of figuring out which one this patient was the deficiency most likely occurring. And I kind of came to the conclusion that B12 is the probable cause for the patient's presentation. Vitamin B12 is necessary for the synthesis of DNA and combined with folic acid, the leading cause, combined with folic acid as the leading cause of megaloblastic anemia, which is accumulation of large blood cells in the bone marrow. The deficiency is obviously having a large impact on her health, and is often a cofactor that converts 5-methyl tetrahydrofolate back into tetrahydrofolate, and then the folate becomes trapped in the 5-metrotetrahydrofolate and leads to deficiency of methionine, which is an essential amino acid. The acid, a patient experiencing this B12 deficiency also is showing a loss in vibratory sense. And as I talked about kind of just a second ago, our patient is experiencing decreased sensation to light touch and vibration in her lower extremities as well. An iron deficiency may be experienced in our patients as well. But it wouldn't be the sole probable cause, as I think that the B12 is showing more so than the iron deficiency. Iron deficiency anemia is the result of iron deficiency. Red blood cells will be at a reduced amount in individual with iron deficiency, which she is hematocrit level and is and was referred to a hematology consultant. A vitamin B6 deficiency is a coenzyme that performs numerous functions. Excuse me. B6 is associated with small red blood cells and many other kind of signs there that I listed, such as cracked skin, rashes, and swollen tongue as well. The patient's not experiencing anything noticeable that would lead me into the diagnosis of a vitamin B6 deficiency over a B12 deficiency or even an iron deficiency. But again, I would say that the probable cause would be that B12 deficiency over the iron deficiency. All right. So the vitamin B12 deficiency also impairs purine and pyrimidine metabolism. As stated on this prior slide, that methionine is a required essential amino acid, and the vitamin B12 is required for the synthase of that amino acid, as B12 catalyzes the transformation of homocysteine to methionine. And it does so by the transferase of methane group from methotetrahydrofolate, and it links that pathway to the pathway of the purine and pyrimidine synthase by the generation of the tetrahydrofolate. A vitamin B12 deficiency can also lead to the reduction of pyrimidine, or the DTTP. Deficiency decreases the amount of coenzymes 5,10 methylene tetrahydrofolate needed for thymidinylate synthetase. Elongation of the newly initiated DNA fragments too can be inhibited due to that B12 deficiency as well. The deficiency can prevent the gap filling that is required as the concentrations of the deoxyribonucleoside triphosphates is not at the required level. All right, then we have some further tests that would assist in differentiating between the three vitamin deficiencies. The first test is the PSB or the PBS test, which is a peripheral blood smear, which examines the individual's red blood cells, white blood cells, and platelets. This test is more of a hands-on test, as you have a healthcare provider looking through a microscope and determine the abnormalities while looking at them through that microscope. And this can give us further information to determine what the diagnosis is for the patient. Another test is the CBC test, which is a complete blood cell test, and this is used to differentiate many different conditions such as anemia, infection, and leukemia. This test can determine the amount of red blood cells, white blood cells, hemoglobin, hematocrit, and platelets. Possible medical condition can come to light during the CBC test, and a diagnosis of B12 deficiency can actually also be seen during the CBC test as well. Or you can just do an individual vitamin B12 deficiency or vitamin B12 blood test can be done to determine if this patient does have deficiency in B12. Then a final test that can be valuable for both the patient and the healthcare workers can be the bone marrow biopsy and aspiration test. A bone marrow test can examine how healthy a patient's bone marrow is and if it's producing a normal amount of bone marrow. It can look at blood cell conditions and cancers of the blood and bone marrow as well. And the accumulation of these tests can lead to results, or further lead us to more concrete results that we can give to this patient as well. And then finally, here are my references. I appreciate you guys watching. Thank you.